Get started?
Sure.
Okay. Thanks so much, everyone, for being here. I'm Erin Hollingsworth. I'm the Adult Services Coordinator here at the Carbondale Library. And we are so glad you all are here this evening. And we're so glad that Dr. Brooke Allen is here this evening to talk about updates in dementia care. So Dr. Allen received her medical degree from the University of Mississippi School of Medicine. And she completed her neurology residency at the University of Colorado, Denver, where she specialized in diagnosing and treating disorders of the nervous system, including diseases and injury of the brain, spinal cord, nerves, and muscles. Dr. Allen is board certified by the American Board of Psychiatry and Neurology and is a member of the American Academy of Neurology and the American Headache Society. We're so glad she's here, and please join me in welcoming Dr. Allen.
Well, I asked for this microphone. I had a cold about a month ago, and I don't know if anyone else has this lingering cough. I've heard a lot of people having it, so I appreciate the microphone, but let me know if you need me to speak up at all. This looks like a fun group. Say. This is a picture of our office in Willits. We're right across from Whole Foods, so Whole Foods is really behind this building. This is a pretty old picture. But we opened an office there. Well, I opened my practice 14 years ago. We opened this office about 4 years ago. So, and I recognize a few of you in the crowd here. Just some disclosures. Anytime we're going to talk about medicine, just so you know who I am. I'm the owner and the only neurologist. I do have 2 PAs that work with me at Roaring Fork Neurology. And then for about 10 years now, I've had a research center called Mountain Neurological Research Center. And in the back, you'll see our 2 research coordinators, Shelby and Leslia, Shelby Parker, Leslia Serrano. And they'll be here afterwards. Just if you have any extra questions, I'll be around too. But our center does perform clinical trials, and we've done work with many pharma companies over the past 10 years, but currently and relevant to this talk are companies that we're working with: Eli Lilly, Novartis, Novo Nordisk, and Cassava. So we'll talk a little bit. And then sometimes we talk about, in a talk like this, just off-label use of medications. And so I just want to give you that, and I'll definitely mention that when I talk about that as well. Okay, so I'm gonna back up. I don't want to give the answer away. Who knows the difference between dementia and Alzheimer's disease? Yes.
So I think dementia is an umbrella term.
Yes.
And Alzheimer's is a very specific type of dementia.
That's right. So Alzheimer's and dementia are often used interchangeably. And the reality is, if you have a relative who had dementia, you probably don't know what type of dementia they had, because back then we weren't getting so specific and we didn't really have ways to be specific about that. Alzheimer's is certainly the most common type of dementia, but there are other types: vascular dementia, which involves the blockage of little tiny blood vessels throughout the brain. Whether you've had clinical strokes or not, you can still develop vascular dementia. Another type is Lewy body dementia. It's a very different presentation. Patients who have Lewy body dementia look a lot like they have Parkinson's disease, but they have memory loss very early, and that's not typical in Parkinson. Patients with Lewy body also tend to have some visual hallucinations, usually friendly ones, usually just some extra people in the room, or setting an extra seat at the table for a small child that isn't there. So, and then frontotemporal is another type of dementia. That's the type I believe that Bruce Willis has, and that's a really rare type, but they're very devastating. They're all devastating, but a particularly devastating type of dementia. So dementia is really just our umbrella term. This is really just looking at the different depending on which study you read, the different prevalence of the disease. And then I threw Parkinson's disease in here too, because if you have Parkinson's disease for a really, really long time, you do have a risk of developing dementia. And then some patients have both Parkinson's disease and Alzheimer's pathology in their brain at the same time. So they can look like they had both of those diseases. So first, I just want to talk a little bit about things that aren't dementia. So a lot of times when individuals come into the office, there's something else going on, or if they're in the hospital, something else is going on. So I want to start with delirium. That's a condition that people can get most often if they're in the ICU, maybe they're being treated for an infection, and they can just get a little loopy. Their nurses are coming in all night, they're not getting enough sleep, they're on medications, maybe for pain control, maybe they're dehydrated, and they can really look like they have dementia. But the key with delirium is that it happens sort of overnight in this extenuating circumstance. And the good news is that if you know someone with dementia, once that issue is treated, whether it was an infection or whatever it was, they typically tend to go back to where they were before that episode. However, having an episode of delirium does mean an additional risk factor for developing dementia later. So there are some people that, because of that experience, will tend to see them in the clinic with some mild cognitive impairment later. Certainly psychiatric disorders can cause people to have trouble with their memory. It kind of makes sense because if you are firing on all cylinders, whether you're anxious or depressed or whatever the issue is, it's really hard to put that information in the filing cabinet of the brain, much less get it out when you need it. So depression and anxiety especially are common causes that people will come in with memory disorder. If you don't eat meat, I would encourage you to either take a B12 supplement or get your B12 level checked to see if you need a supplement. B12 is really important for brain and spine function. We always screen people for thyroid disease. Thyroid disease in and of itself can cause memory change. And then I listed, alcohol use disorder. So that's usually a hot topic in a talk like this, is how much alcohol is okay. And unfortunately, the data is really pointing us in the direction that no regular amount of alcohol is very safe at all. Sorry to bring that bad news tonight. Rarely, but I listed it because it is still out there. Syphilis can cause some memory trouble. HIV certainly can. And if you have uncontrolled high blood pressure, you can have episodic memory loss as well. Medications are certainly on the list. So opioids, a lot of pain medicines can cause memory change. Benzodiazepines, so those are drugs like Valium, Ativan, Xanax. Those can cause quite a bit of memory difficulty. Even things like Benadryl. How many of you have ever taken a Tylenol PM? Yeah, right? So, taking one here or there, not a big deal, but the diphenhydramine, which is Benadryl, which is in that medication, is an anticholinergic drug. So it can actually cause cognitive slowing just for the amount of time that it's in your body. So I definitely don't recommend people do that. Antihistamines are on the list as well, and some mixed data coming out lately. You might have heard about proton pump inhibitors such as Nexium are starting to make the list, which is unfortunate because they do help with other issues. Sometimes the person actually has a brain tumor or a stroke or some other structural problem in the brain. So we do look at an MRI. Cancer anywhere in the body can cause memory change. Stroke can cause memory change. Autoimmune diseases like MS, lupus, and people that have sleep apnea or other sorts of respiratory disorders where their oxygen is really low can present as if they have a dementia. And then fragmented sleep in general, just not sleeping. If you've ever experienced a period of time, if you've ever gone through menopause, you know you're not right when you're not sleeping. So, and then hearing loss is a risk factor, as the gentleman pointed out earlier. And the data is really unclear as to why, but it probably has something to do with the way we attend to tasks, right? The way our brain has to pay attention, and when we don't hear, when we're missing some of that sensory input, it puts our brain in overload. I also think there's probably something to social isolation for people that have hearing loss, because every person I know who has hearing loss tends to withdraw. They stop going to dinners, they stop playing games, they stop going to bridge. And you'll see in a second that social isolation is one of our risk factors for dementia as well. So treating that, and that's for all the women in the room who've been telling their husbands to wear their hearing aids. So let's talk a second about normal aging and mild cognitive impairment. Ron Peterson is the physician, the neurologist at Mayo Clinic, who coined this term MCI, mild cognitive impairment, and it's sort of the stage in between normal aging and dementia. So it's not quite dementia, but it's definitely not normal. And I would say this is the #1 reason people come to our clinic, is to find out, hey, is this normal? Because my friends are as bad as I am. Am I okay? And usually, if you are worried, then you're probably fine. But if somebody else is worried about you, that is a little bit more of a red flag for us. So Dr. Peterson says, successful aging is rare, which I think is a fantastic quote. And typical aging, just like any other part of your body, you have decline. And what you can see on this graph to the right is that a normal person is going to start to have this downward slope. So that yellow line is not staying perfect over time. You are declining if you're on that yellow line, and that's just from aging, right? But what can happen in Alzheimer's disease specifically is that for 10 to 15 years, even before your first symptom, you are laying down some abnormal proteins in the brain, specifically amyloid plaques and tau tangles. And those two abnormal proteins then wreak havoc on the little areas all around that in the brain, causes the glia to really get all tangled up and be reactive. And so it's a very hard thing to undo once it's been going on for a while, okay? It's estimated that about 14 to 18% of individuals over 70 have MCI. And what we're finding through the research is that in that mild cognitive impairment stage, that might actually be the best time to intervene before there's too much damage in the brain. And we've learned that through some clinical trials that we'll talk about. If you do get a diagnosis of MCI, your risk of developing true dementia is about 3 times more than the next person in the next 2 to 5 years. So it's a pretty serious diagnosis, and one that we take very seriously at the clinic and really start to help people think through what steps they're going to take. So let's talk a little bit about the risk factors for dementia. #1 risk factor is age, which makes sense. Females are slightly more likely to have dementia than males, but probably just because they live longer, right? I don't know that there's anything special about that. We're going to talk a little bit about the ApoE4 gene. Actually, maybe I'll talk about that now. So when we think about genetics in Alzheimer's, there certainly can be instances of early stage disease where individuals develop memory changes and get a diagnosis of dementia before the age of 55 or 60. That's pretty rare, but there are a handful of genes associated with that. I'm not really going to talk about that. I'm going to talk about late onset Alzheimer's genetics. So that's getting Alzheimer's after the age of 65, essentially. So we have the opportunity at the APO4E locus to have 2 genes there. It can be an E2, an E3, or an E4. And then you have 2 of them, so there's some combination of them. what you'll see here is that it's pretty, pretty high risk if you have 2 of the E4s. That's the one on the very end there. That's only about 4% of the population. So that means you got 1 of your mom's E4s and 1 of your dad's E4s. That's pretty rare. I think we have 2 people we follow out of a lot of patients that have that profile. More commonly, we see an E3 and an E4. That's what I am, and I found that out just from doing 23andMe, which goes on sale always at the holidays. So if you're interested, it's half off. I'm no stock in the company or anything, but so an E3 and an E4 means you have 1 bad gene, the E4, and then if you have 2 E3s, you can see your risk is way down here. And then somehow E2 mixed with an E3 seems to be protective. So it seems to be better. We don't really know why. Genetics are hard because if you have 2 E4s, which is the worst situation, you still only have about a 40 to 60%, depending on the study you read, chance of getting Alzheimer's. If you have 1 E4 and really a lot of anything else, you've got about a 25 to 30% chance. And even if you have nothing, you still have a 10 to 15% chance of having Alzheimer's disease. So genetics are not the only part of the story, but they do come into play as we think about risk and what we're going to do. So dementia, the term itself, is different from mild cognitive impairment only in that some part of daily functioning is impaired. So you can't drive anymore because you keep bumping into other cars. You can't manage your finances anymore on your own. You can't sort and pick out your laundry for an outfit, right? Those are functional things that happen. Whereas somebody with mild cognitive impairment, they might repeat themselves all the time or, miss some appointments and things like that, but they're functionally they're doing pretty well. So that's really kind of when we start to use the term dementia, is when a function of daily life has changed. This is just a picture of the amyloid plaques, which are these little clusters here, and the tau tangles, which are off to the side, the little T-looking things. And then all around there, those white areas, that's reactive nucleosis. So that's the damage that's done because these abnormal proteins are in the brain. And we think, we all have a normal amount of amyloid and a normal amount of tau in the brain, but something's going on in Alzheimer's disease where you're either producing too much of it or you're not able to clear out those proteins normally, or some combination of the two. And there are a lot of theories about this. This comes up in the news all the time. So here are some examples of normal aging. This will give you all a sigh of relief. So forgetting the name of an acquaintance, right? Forgetting a word you want to say, but you might remember it later. Maybe you don't, that's okay. Missing a monthly payment, making a bad decision every now and then. Forgetting the date, but remembering it later, or losing things, misplacing things. So things that are not normal, a change in work performance. So the boss is talking to you because you're really having trouble with the spreadsheets and things you used to be able to do very well. Making a big mistake in finances, getting lost, repeating questions, stories, statements, forgetting appointments, changes in your judgment, reasoning, trouble learning a new tool. This is a big one. So we have a lot of patients who might live between Glenwood and Phoenix, and they come in because the only thing that's changed is that they're having trouble with their remote control, right? It's different in each location. Or they're having trouble working the microwave. So those are some examples of how learning a tool, and certainly a new tool, any sort of new computer or anything like that can feel very overwhelming for someone who has dementia. Forgetting the month, the year, the season. And then on the right side, what you really see is something that is pretty common in people that have mild cognitive impairment and dementia. And incidence is as high as 40% that people can have depression, anxiety, aggression, irritability, apathy, sort of withdrawing from activities, or even a big change in their personality or their behavior. And they've really looked at the confounding factors, and it's not just because they have this thing going on. There's some sort of change in the brain happening, and this is really part of the disease. So that makes it especially tough for caregivers. Mild cognitive impairment, we kind of talked about, it's pretty common. In the early 70s, you got about a 10% chance of having it. So it's a very common phenomenon. This is what a typical neurology appointment looks like at our office. We always start with patient and family interview. That clinical information is more valuable than anything else on this list, as far as I'm concerned. We give a quick screening exam in the office called the MOCA, the Montreal Cognitive Assessment. This is the one that former President Trump brags about, that he got a 30 out of 30 on. So you might have heard about that. We talk about family history. So 10 to 30% risk if you have a first degree relative who had dementia. That's really not even knowing your genetic status or anything like that. We look at your medical history. Oftentimes we'll do neuropsychological testing to tease out what, if any, mental health component there may be in terms of learning and memory. If you have dementia, we would do a clinical dementia rating scale, which really looks at function. And then we check for lab work. We're looking for those reversible causes, your thyroid, your B12. Are you anemic? Is there something else going on that could be contributing? We usually get an MRI of the brain to rule out any structural disease, and then sometimes on a brain scan we can see areas of atrophy, certain parts of the brain that are more likely to be shrinking down in Alzheimer's disease. And then finally, more recently, we are interested in an amyloid assessment. So amyloid is that protein, that little clump of proteins I mentioned earlier, and there used to be only two ways to find out if you have amyloid in your brain. One is to get a PET scan, and it's not any kind of PET scan we have in the Valley. It's a very specialized PET scan where they fly in an amyloid tracer, inject it into your arm, and then that tracer tags the parts of the brain that have amyloid in it. Another way to get that done, which isn't very pleasant, is to do a spinal tap and look at that fluid, look for those amyloid beta protein profiles in the spinal fluid. And then thankfully, in the last couple of years, we actually have some blood assays now where we're able to draw blood and get some of that same information. And it looks like the sensitivity is coming in just as high as the PET scans and the spinal taps. So that's good news for everyone. Just a quick shout out for our research team right here. Eli Lilly approached us this week about a study. There are many blood assays. None of them are yet approved by insurance, but Lilly has developed one called p-tau217. And the study they're doing is they are putting, I believe it's a 1-to-1 randomization. So half of the people who sign up for the study get the blood draw and get to know their results. I get to know their results because this is a prospective or observational study. And they're really looking at how physician behavior and recommendations change based on that information. So it's kind of a cool study, different from anything we've ever done. And then the other half, I don't think they get the test. Is that right? Yeah. So that's something, if you wanted to sign up for it, everything's free in a clinical trial, but you might have a chance of getting into that placebo group too. That study, I believe, will open in May or June of this year. Okay, I always say if I could give one test to a patient, if I had 5 minutes to spend with them, I would do this test. I would have them draw a clock. So I want to show you, these are actual clocks from my clinic. So the instructions on this are to draw a clock, put all the numbers on it, and make the hands say 10 past 11. When we think about clocks, it's a great way to think about visual spatial skills. And when I watch someone draw a clock, I'm always thinking about driving, right? How good of a driver is this person based on the clock they're going to draw here? So this is a pretty good clock. Would you agree? It's a good one. This is another clock. One could think maybe about this clock that this could be someone who had a stroke who's sort of neglecting the left side. You see they didn't put any numbers there. Maybe they had some neglect. This is a clock for someone who probably has some trouble with motor planning and executive function, multitasking, right? So they're really having a hard time figuring out the spacing and where to get everything in the right place. This is a clock. I find this clock fascinating because it's very detailed, and there are components of the clock that are extremely accurate. But I think you can tell there's a lot going on for this person, right? And then this last one, probably the most interesting clock I've ever seen. This was a patient with frontal temporal dementia, the type that Bruce Willis has, and it is like a whole different type of dementia, as you can see. So what happens to people who get a diagnosis of mild cognitive impairment? So we know they're 3 times more likely to develop dementia over the next 2 to 5 years. But also, we know that almost half of them, depending on which study you read, will revert back to normal. And a lot of times that's because you found some sort of problem through your workup that you've been able to address, right? Some reversible cause. But I just put a little note here, because I think there's not a lot of data. I mean, there's not a lot of sentiment about this, but the data shows us that worldwide, the incidence of dementia is actually going down. And probably the reason is that we are more aggressive as physicians about dealing with cardiovascular risk factors, right? Getting your blood pressure lower, treating you for diabetes, if you have high cholesterol, getting your lipids down. So I think that's some bit of good news that we do have as we age. Yeah.
Why is there such a widespread in the percentage report?
That's a great question. So anytime you do a study, you really have, in a study like this, you have to follow people over a very long period of time. And so those studies end up having sometimes only 16 people in this study, 106 people in this study. So then they all get weighted based on those numbers. And they're also very hard to follow, right? Because how many times do you go to your doctor's office, you mention something about memory, but then it never comes up again, right? If it's not a big problem for you. So I think a lot of people believe this number is a lot higher than it is. And I personally think it's not as low as 13%. I think it is closer to 50%. So I do think people come in. One of the things we'll talk about is getting a hearing aid. Getting a hearing aid is huge. It's super simple. And it's a reversible cause, and you're reversing an actual risk factor for dementia as well. All right. So traditionally, we've had 2 drugs to work with for the last few decades. The first category are cholinesterase inhibitors. Dee Dee, you're asking me about Exelon earlier. That falls into that category. Aricept or donepezil is another one. These medicines basically keep a little more acetylcholine floating around in the brain throughout your day. Acetylcholine is the chemical that we use to store memories and to unlock that filing cabinet and get that memory back out, okay? So They also have a lot of side effects. 1 in 5 people will develop pretty dramatic diarrhea on this medicine and have to stop. It's not the new them. The diarrhea goes away. But that tends to be a problem for a lot of people that try it. And there's really not that much benefit that we see. The data really suggests that only in that first year of a dementia diagnosis does that medication do anything significant in terms of helping you with memory. I do give patients the option to try these medicines if they want, just understanding that we don't have a lot of good experience with them. And they are usually just used short term. However, I put a note up here because I read a study this week that in a repurposing drug trial, they found out that these types of drugs may actually prevent macular degeneration. So, for what it's worth. On the other side, we have memantine or Namenda. Memantine is a medication that activates glutamate, so it works on a totally different chemical in the brain. And it really does show a pretty modest benefit, but for people at later stages of the disease, which is nice. What they did, the biggest thing they showed in their study is that individuals who were taking that were able to stay home and be independent longer than people who weren't taking it. Everyone talks about diet, so we'll talk about diet for a minute. The Mediterranean diet is very popular. There's also the MIND diet, M-I-N-D, which is a diet that is a little bit of a combination of the Mediterranean diet and the DASH diet, which is a high blood pressure or low salt diet. But essentially, we're looking at fresh fruits, vegetables, and fish being the highest correlation, and not a treatment for dementia, but certainly a higher correlation of people who eat these healthier things have less incidence of dementia. Flavonoids, berries in particular, strawberries and blueberries. There's some great data that those may actually be correlated with a lower risk of dementia. So again, not a treatment for dementia, but a correlated risk factor. Certainly, if you have a vitamin deficiency, you would want to treat that. And then in the last year, vitamin E has kind of been up and down over a decade now, but vitamin E is sort of back. 1,000 international units twice a day is the new recommendation. The data is still pretty mixed on it, but it's probably very safe to do that. And then vitamin D3, there's some mixed data that low vitamin D may be an additional risk factor. So I do recommend patients check their vitamin D level and treat that as well. Diet studies, though, are notoriously difficult because individuals who are in these studies are retrospective, so they are having to remember what it is they've been eating. And by the way, we're talking about a population of people who might not be remembering very well. But I think more importantly, and what you're going to see in a second, is that the more years of education you have, the lower, well, I'll say it differently, the longer you can go without developing mild cognitive impairment, okay? So people who have more years of education tend to also be the same people eating fresh fruits, vegetables, fish, because they're educated about it and they can afford it, right? So diet studies are really confounded and very difficult to do. Lifestyle modifications, exercise, this is always a controversial one because there are all kinds of good reasons to exercise, not just for dementia prevention. But it does seem that exercise has short-term benefits rather than long-term disease-modifying benefits. So that's something, and it's probably better if you look at the data, if you're doing that level of exercise, excuse me, if you're doing that level of exercise in your early adult or middle adult years, more so than your later years. All kinds of reasons to continue to exercise as you're older, primarily fall prevention and balance, but there are some limitations to the exercise data. Socialization is huge. We know that the more you socialize, the longer you're gonna put off having more severe dementia deficits. There's even some data on mindfulness and meditation. I included here, and I'm happy to provide these slides to you guys. There's a specific mantra that was studied by the Alzheimer's prevention group, and they showed that MRI scans after doing this mantra for a period of 3 months, those patients were able to increase cortical thickness in the brain. So there's probably a lot to mindfulness. Personally, I think that makes sense, right? Because when you're able to calm your brain, you're able to focus better, you're able to concentrate more, so you're functionally better. Obviously, addressing your sleep issues, wearing hearing aids. And then I included support groups here for caregivers, because caregivers are really running the show for these individuals. And if they don't have support and they're unhappy, nothing's going well, right? And then risk factor sorry, this is a 30-minute rule. This is just a good reminder. 30 minutes of cognitive stimulation every day. We'll talk about what that means. 30 minutes of physical activity, and then 30 minutes of something social. Importantly, the social activity does not count if it's your partner. So I sit on the couch with my husband in the evening and stare at the computer, the TV, right? That's not social. So I'm social when I go have coffee with someone or I go take a walk, right? You can knock all of these out with a walk and a podcast, right?
So that's
No, that would be considered cognitive stimulation.
you can't walk with someone.
You can if you're listening to the same podcast. And then you go for coffee after and discuss. But I would keep coming back to risk factor modification. These are things you're doing with your primary care doctor anyway. And there's a lot of data that I'll show you here in a second that really addressing these things is the most tangible thing that you can do to control your risk, or lower your risk, I should say. So addressing high blood pressure, not smoking, not abusing alcohol, addressing high lipids, addressing early glucose intolerance, which is that stage right before diabetes, addressing your hearing loss, getting checked for sleep apnea if you're snoring, addressing any other sleep disorder, not being inactive, brain trauma, so just wearing a helmet if you're doing a high-risk sport, and then avoiding social isolation. These are all things we can work on. So in terms of cognitive stimulation, these studies are also sort of mixed, but there does seem to be a difference between engagement that's productive versus engagement that is receptive. And I'm going to give you some examples. The activity has to be sustained for at least 6 to 8 weeks, and it needs to be novel or new to you, right? So if you played the flute in high school and now you're going to play the flute again, that wouldn't count. And it needs to be slightly cognitively demanding. Interestingly, there's no data to support these brain training games that people sell online.
Does that mean the data doesn't exist, or the data doesn't
The
directly?
data does exist and doesn't show any difference. Good question. So productive engagement, it requires active learning, sustained activation of your working memory, your long-term memory, other executive processes. Receptive engagement, or that's more like listening to music, reading a National Geographic, watching a documentary about something complex. Those are still pretty receptive, right? You're not actively doing quite the same thing. Here are some examples. So learning or relearning an instrument, I shouldn't have said relearning, learning an instrument, complex hobby, digital photography, quilting, knitting, bird watching, woodworking, calligraphy, building models, embroidery, fly fishing. woodworking or carpentry for habitat, art, dancing, exercise, learning to sing, a new game, a new language, a new computer skill, ooh, super hard, yoga or Tai Chi, also good for balance, or being in your local theater. Here are a few more. I kind of came up with these as we were doing a presentation, but I think teaching is one of the best ways to do this, right? Because teaching requires a lot of working memory. Again, we're coming back to these 7 risk factors. This was a study, 2011. They surmised that 10 to 25% of Alzheimer's cases, or that these individuals could have a 10 to 25% lower risk of Alzheimer's if they just worked on these 7 risk factors. So diabetes, treating it, smoking, not doing it, depression, treating it, cognitive inactivity, lower education levels, so if you're pursuing higher education, physical activity, and then the 2 in greenish yellow there. Interestingly, the data really showed that it was more important that you control your blood pressure midlife and that you get to a healthy weight midlife than later in life, for what it's worth. So we'll touch briefly on a couple of new therapies. So for a long time, I would say 20, 25 years now, the pharma companies have been looking at medicines that will remove those plaques from the brain, remove amyloid. So in order to be a candidate for a drug like this, we have to know you have amyloid. How would we know that? PET scan, spinal tap, or one of these newer blood assays. So the first one that got approved was about 2 years ago, and it's at the bottom here, aducanumab. And you might have read about this. It's pretty controversial because their studies were sort of interrupted by the COVID pandemic, and they basically, the pharma companies drew out the data that they believed was important and said, based on these small parts of these studies, we think you should approve this drug. That's never been done, but it was done for aducanumab. And you had, all of these physicians resigning on these FDA councils is a very, very big deal in the world of neurology. And they fast-tracked it, it got approved, and then CMS, that's who pays Medicare, that's Medicare, they basically said, well, we're not gonna pay for that. So it's been a really tough road for aducanumab. We actually never had a patient take it, I do not believe. The pharma company that makes aducanumab, which is Biogen, has now invested in this other drug called Leqembi. And as such, they decided to just pull aducanumab off the market. So it got pulled off the market about 2 weeks ago. Lecanemab got approved in January of 23, and CMS Medicare said, we're not sure we can pay for that. And they approved it in July of 23 to say, okay, well, we'll pay you. We're gonna pay about $28,000 a year for this drug per person. So it's an infusion in your vein, about 30 minutes long, every 2 weeks for the year. And so the cost is in the mid-20s. This is still really having a hard time coming online. We have only infused 1 or 2 people at our clinic, and part of the problem has just been getting access to the medication, and there's a lot that goes with it. So, lecanemab is a medication that when it removes those plaques from the brain, it leaves a little scar. And the scar can look like swelling, edema, or in rare cases, there can actually be bleeding left behind where that plaque was, okay? In the clinical trials, individuals who did have those little scars or swelling in the brain, most of them had no symptoms at all. In the clinical trial, we monitor with serial MRI scans every few months. They were just discovered just by looking, but the patient had no symptoms. But in the individuals that did have symptoms, they were big. They were headache, nausea, vomiting, falling. There were a couple of deaths from falls and hitting their heads. So these drugs are not without side effects at all. The other thing to know is, well, what's really the benefit of these drugs? These anti-amyloid therapies have shown very modest gains. What they do is they take someone who's on a certain trajectory of decline and they slow that trajectory. They do not improve patient function. So it's a big decision to come to our clinic every 2 weeks to get an infusion just to slow your disease down. But there are certainly people that are in a situation where they want to do that for a lot of good reasons. But that's kind of where we are with aducanumab, with Leqembi.
Slow down for how long?
So, great question. The studies are really reporting out about 36 months of data at this point, and they are continuing to show a separation between the placebo group, so the group that didn't get any medicine, and the Leqembi group, who's declining at a slower rate, I should say. But you're right, these are new drugs, and so we don't have long-term data. So those brain changes I mentioned, those are called amyloid-relating imaging abnormalities. We call it ARIA for short. You can also, on these medicines, have some flu-like symptoms. It doesn't mean you can't take the drug again, but we do give some pre-medications just to make it easier to tolerate the drugs in the clinic. So that's the amyloid story right now of what's available and FDA approved. There is another drug. This is a drug called donanemab. The pharma company for this one is Eli Lilly. Works in a very similar way to Leqembi. What I like about this trial and why we took this trial on, enrollment is now closed, but we took this trial on because there was a start and a finish, right? So they said, you're going to take donanemab for X amount of months, and then we're going to stop the medicine, and then we're going to monitor your PET scans, and we're going to see if your amyloid comes back. And to me, that's an ethical study to do because a lot of these companies won't look at that because they want these patients to take their drug in perpetuity. It's a financial decision on their part. But the reality is, it took you 10 to 15 years to put that amyloid down in the brain. If you remove it all, it's probably going to take a really long time for it to build back up. You probably don't need to stay on that medicine forever. Donanemab did submit to the FDA, and they appeared to be on a really good track until about a week ago, where they got a letter, and the letter just said that they wanted to go back and look through their phase 3 data. So it was a little bit of a step backwards for the company. They're not really sure why, but they do have, I believe, their date that the FDA has said they're going to make a final decision is in July. But again, it works similar to Leqembi. So these drugs, you'll notice they all end in MAB. Well, it turns out they ran out of words to use. So now they have a new suffix, and it's horrible. This is rimturnitug. So this is Eli Lilly's next anti-amyloid clearing, amyloid clearing medication. But now you're going to start to see these suffixes, turnitug. Why is Lilly pursuing this? They already have donanemab that's almost there. They're pursuing it because they think that there's a better immune profile. All of these drugs are really working with your own immune system, and they think that there's going to be a lower side effect profile with this one. So we do have this trial. Is it open for new patients right now? No. Maybe there's a lower risk of ARIA. So those are the sorts of things they're looking at. They're really just trying to find something that works that patients can tolerate. Yes?
So okay, so are these drugs supposed to be a lot aggressive and stronger than working with your own immune system and natural diet and exercise?
No, they're very specific. So they only work at the level of the amyloid plaque. And there's so much else that's part of this story, right? We're really just talking about one thing. And we're gonna talk about some other mechanisms that they've looked at too. But anti-amyloid therapy has been around for 2 decades now, and we're just now seeing the first ones that do anything at all, quite frankly.
So, but your own immune system, if you work with building up your own immune system, is there a specific, would that just help, or is it specific to the amyloid?
No, it's the immune response to the amyloid being removed. Yeah, good question. So this is a really interesting study that we conducted that has, the enrollment has closed globally. It's an oral drug, so we love that. It's called Simifilum, and it's manufactured by a company called Cassava. And this medication targets filamin A. Filamin A is a really important marker or part of the process of the amyloid plaque story, but it's not the amyloid plaque itself. So a lot of things have to happen for that amyloid plaque to form. And so this is really looking upstream from the plaque and addressing it in a different way. This medication targets that filamin A, which we know is a problem in Alzheimer's. It reduces tau hyperphosphorylation. It reduces neuroinflammation by blocking cytokine release, and also improves insulin resistance. The name of those trials, if you want to read about them, are Rethink-ALZ and Refocus-ALZ. FDA always requires you to do 2 sister studies that are very similar and have similar results to even consider putting those to market. They do show in the phase 2 trials, and we don't have the phase 3 readout yet, but in the phase 2 trials, it did show that the drug worked better in that mild to moderate category, kind of a theme with all of this. Interestingly, no risk of ARIA at all, because you're not doing anything to the amyloid plaque that's there. You're back upstream, preventing it from happening in the first place. And then some of the phase 2 data, limited number of patients actually showed improvement that was sustained over 6 months. So that is a very different and promising study with a completely different mechanism of action. We should get the final readout by October 2024, maybe early 2025. I think Rethink is ahead of Refocus. So the FDA probably won't consider that for at least another year, but it is on track to probably be a player in the Alzheimer's space. Other things that are being studied, there are a number of medications targeting tau proteins. We look at these studies from time to time, and we really only take studies where we feel hopeful that there's going to be a good outcome. So I think we've looked at a couple of tau studies, but we've never done one. We did a study called, what's that study called? Novo Nordisk, their trial. I can't remember. Yeah. So it's Ozempic, which is in the news everywhere. It's semaglutide, and that is an oral medication in this particular study. It comes in many different forms. And that study is closed for enrollment, and the readout hasn't come yet. But it's an interesting molecule to think about because it does promote better insulin in your body, and it lowers inflammation. So it's kind of an interesting study. We're looking forward to seeing the results from that. And then there are some great studies going on looking at what is the right kind of exercise. Should it be cardiovascular? Should it be walking? Should it be weightlifting? And that sort of thing, as well as diet studies, which are harder to do. And then I'll just mention, we have a company that we work with, Otsuka, who they have developed a medication that they believe will help in agitation in individuals who have moderate to severe Alzheimer's. So that's another study that we have going on as well. And enrollment is open for that study. So in the back, we have Shelby and Leslia. We can talk a little bit more. We do, from time to time, memory screening days. And I just want to put a plug in for this. This is a great way to get a relative or a friend in because you can say, hey, let's go get our memory tested, right? You can go together. Some people are very, very afraid of coming to a neurologist to do a memory test. But this is very low pressure. You see our research team. You don't have a medical visit. It's a pre-screening that we do, but we give you that MOCA exam and then some tips and tricks, especially if you're normal, just to sort of give you peace of mind. But if you're not normal, we then offer you an appointment if you'd like it as well. Shelby and Leslia will also be signing patients up tonight if you're interested in just getting on a database list. From time to time, studies will come up. Maybe you're not in the right age category for this study, but you might be for another. And that just allows them to give you a call and let you know about things that we have obtained at the clinic. You can also sign up tonight if you're interested in that PTAL study that's coming up. That's that blood test that gives you an idea of your risk of developing mild cognitive impairment or dementia. I actually think you have to have some complaints of memory to get into that study. And then just important to know that these blood assays are out. We do have a relationship with Quest and LabCorp. I think both of those entities are offering a couple of blood tests that insurance is not quite paying for. The cost is around $750. I think we charge $40 or something like that to draw the blood and handle all of the logistics getting it to the lab. But that is something that some individuals choose to do because they're thinking about a drug like Leqembi that can remove plaque, so they want to know if they have plaque in the brain. So those are just some things that we would love if you want to volunteer, if you want to participate, or bring your friends to a free screening memory day. So I'll just take questions now and see, yes, in the back.
There was a thing on 60 Minutes not too long ago that I can't believe the doctor's name is Razzie, who developed implants for people who had Parkinson's. So it works for some people, but they also done some work with dementia patients who it didn't cure it, but it improved their current state. You know, all of this medication is like, you know, throwing out everything to see what sticks to the wall. And I was wondering if you have any comment on, he was not ready to do a lot of stuff, as I understood it. But could you comment on some of that?
Yeah, so you're referring to neuromodulation. Deep brain stimulation is another word for it. And you might know someone with Parkinson's disease who had a deep brain stimulator implanted into their brain. Specifically in Parkinson, you put it in the substantia nigra or the thalamus, just depending on what kinds of symptoms you had. And then you have a little remote control you put up to your battery, kind of where it's like a pacemaker under your skin. And you can turn it on or off depending on the symptoms you're having. The problem with neuromodulation in a disease like Alzheimer's is that Alzheimer's isn't in one specific tiny part of the brain, right? What we know is that these amyloid plaques start in the temporal lobes, which is where your hippocampus and your memory center is. So you'll start to see a large accumulation there. Then they they develop and land in the frontal lobe, right? That's your inhibition center. So when you want to say something mean, but you don't because your frontal lobe is working, you start to get some plaques developing in that region. And then you have plaques in the parietal region of the brain as well, and really throughout the subcortical region. So it would be very difficult. I mean, I'm not leading that trial or thinking about leading a trial like that, but I think it would be very difficult to know where to put a stimulator. So stay tuned for more on that. But yeah, there's so many areas involved in Alzheimer's.
Okay.
You know, any credible tests or anything done for Prevagen?
Great question. Prevagen, the question is about Prevagen. So Prevagen in general, it's very difficult to find studies on it. And if you do a deep dive on Prevagen, you'll actually get to these FDA warning letters. The FDA is sent to the company that makes Prevagen, really for making claims that are not supported by any data. What I usually say to patients about Prevagen is it's probably not going to hurt you, except it may hurt you financially. I think it does cost quite a bit of money. But anecdotally, people tell me that Prevagen helps them. And there's this thing called the placebo effect, which is very real in all diseases. So anytime a drug's going to come to market, you have to measure it against placebo. And the reason is just thinking that you are going to take a medicine that might help can raise your improvement in that disease state by 30, even 40% in some cases. So whenever a drug company is saying our drug works, what they're really saying is our drug works 50% of the time and placebo works 40% of the time. So we have a 10% benefit. We're always going against placebo. So I do think there is a lot of value in if you have autonomy and you feel like you're taking something, are you going to feel better? Maybe you'll also start making some better diet choices. Maybe you'll start exercising too. So I can't really say why, but I do have a lot of people tell me that they do really well on Prevagen.
Yeah, it's hard to self-test. To go so far and then think of too much change. And think, well, if I like this now, what would it been like if I hadn't been taking it?
Right.
And then you run across the
It's
road
hard to
and talk
know.
about it. He really felt like he improved way better. I mean, I thought, well, maybe I'll start again a little bit. Now look, it's double.
Depends on how much money you have.
Yeah. I'm not good to go.
Yes.
Is there any way to increase his acetylcholine? Is that what you meant?
Acetylcholine?
Acetylcholine in your body now? Like, is there any way
Good
to
question.
increase it now?
Not that I'm aware of. So these acetylcholinesterase inhibitors, so acetylcholinesterase is the enzyme that breaks down acetylcholine between the nerve junction. And so if you take an acetylcholinesterase inhibitor, meaning it's working against that breakdown enzyme, you're going to leave more floating around. But yeah, I don't know other than a specific target, mechanism of action. I don't know of anything natural that does that, but it doesn't mean there isn't anything. Just don't know. Yeah.
A lot of questions, but I'll just keep it to another. I think it's called barometric. It's called people. I worked with someone who had severe concussion, and then she was like unable to function, and she said that was what helped her the most. And I'm wondering, does that also help?
So
Memory stuff, because does it have to do with oxygen also?
it's a great question. So there is some really good data coming out of, I believe it's University of Miami. And they barometric hyper. There is some promise. It's a difficult placebo study to do, right? Because you do feel the effects of being in a real tank versus not a tank. So kind of like with psychedelic therapy, it's really hard to have a placebo arm. The placebo arm in psychedelic therapy is Valium, right? So Valium versus mushrooms. So you probably know what you're on. So it's a little bit more challenging. So the data is not as strong, but I do think there is some decent data in the head injury community. I have not seen any data in Alzheimer's for hyperbaric chamber. So there's one at the Mid-Valley Medical Center, the old Wynn Institute, I believe it's over there. Yeah. And it's great for, healing infections, skin disease, kinds of things. Yes.
With these medications and trials and things like that, is it specific to Alzheimer's, or do they look at the other different types of dementias as well? And if they've had any different, outcomes or anything?
Yeah, so a great resource is clinicaltrials.gov, G-O-V. You can pretty much type in any kind of dementia or any disease state at all, and you can see which trials are enrolling. If you click on the trial, you can go down and see states and what trials we have at any given moment. But we have run one for vascular dementia as well as Alzheimer's. We also do some MS and headache trials. But there are trials for all of these types of dementia. You can just find them on clinicaltrials.gov.
Okay, and the ones that you kind of went over, are those mostly Alzheimer's?
They're mainly Alzheimer's, with the exception of the Novo Nordisk trial with semaglutide. That one, they did allow us to include patients with vascular dementia as well. But yeah, the study teams really dictate who can get in the trial. Yes.
This is kind of, when I was a kid, I want you, when I ask a question, I want you to say, great question. I remember in our neighborhood or family, whatever, that they were saying aluminum cooking pans cause Alzheimer's. Oh, yeah, long, yeah. Great question.
Great question. Yeah, so I think the kind of aluminum that is used now in cooking pans is not a known risk factor for dementia. Could there have been something back then that was questionable? It's possible, but no, there are no current worries about that. Yes. Dee Dee.
Do you have any potential impact ideas of, for example, factory stimulation or light stimulation, like 40 megahertz or whatever it is?
Yeah, there's some interesting data looking at light therapy, and we have a few light artists in the Valley, which is super interesting and cool. They've been a part of some of the, there used to be a group called Brain Train, I don't know if you remember that. Did a lot of good work, but there is definite data for light therapy and depression, and people that have depression can sometimes present with memory change, and so I think some of that data has been confounded in that way, but I don't know specifically for Alzheimer's, but I'm glad that you spoke, because I want to tell people who you are. So Dee Dee took it upon herself to start an Alzheimer or dementia support group in the last year and has held several meetings. We actually had two support groups, one in Pickens County and one in Carbondale for a long, long time. And the individuals who are running them just got very, very tired, quite frankly. And Dee Dee says she's not going to keep doing it. So if anyone else wants to volunteer, we've offered our space at the Willits Care Center as a place that you're welcome to hold your meetings anytime. We'll even throw in some money for refreshments. But I'm glad we're talking about support groups. There's a study that, or a survey that came out on NPR today looking at what do people need, right? Do they need these medicines? They don't work very well, quite frankly. What they need is support. They need to know what government resources are available. what books to read, what podcasts to listen to. And I think the biggest issue in our country, in other countries, they prioritize caring for elderly people. And they pay individuals to care for the elderly. And honestly, in America, we rely on women to do it most of the time. And we rely on them to do it without pay. And it's a really, really serious problem in our country. So anyway, that's a tough one.
You do. You do pattern recognition and stuff like that as part of that. To show a pattern and you gotta pick up on it, start marking.
Yes, okay. So the MOCA exam basically takes pieces of a formal neuropsychological exam and it condenses it into about a 22 question test. Formal neuropsych testing is what you're describing, and that I will do if I'm not sure what's going on, because it can give me a lot of data, especially if someone's in the very, very early stages. They've got high cognitive reserve, they're very well educated, but they're scoring a perfect score on the MOCA, but know something's going on. That's a great time to get a neuropsych test. So an example would be the numbers 7, 2, and 4 are flashing in green, and they only want you to push the button when you see a red number. And then they switch the rules, and then they only want you to push the button when you see a 7. It's a very difficult test, and it can go on for about 8 hours. So you can imagine there are a lot of people. I'm not going to put them through that. But yes, there is some of that gleaned from the MOCA, but mostly you're really talking about neuropsych testing.
I'm gonna tell you what I like to do on the MOCA, what I'm gonna miss and what I can do.
Because you've memorized it?
The test didn't seem to say, you got the prompt, you got the building type diagram, you got a.
What are the 5 words?
I'll tell you, I'm not gonna be able to get it. The last time I took it though, the nurse was gonna do it, she sat there and she, named 3 words. And she was reading. And then she wanted to go through all the rest of them, and then come back to them, and I had time to learn it there while she said, while just laying there in front of me.
Oh, you were looking at it.
Yeah,
I mean, we have patients that come in and they walk through the door, face, piano, green, happiness, they're ready. Yes, Dee Dee.
I flunked it the first time because the only words I could remember were chumps.
And he did make it newsworthy, yes. Everyone sort of looked it up. Yes, our cards are on the table out here. Feel free to grab one. Yes.
So if someone went in and had the MOCA test and they scored a 21, but
it's out of 30,
yes,
by the way.
And I think that falls in the mild range. What would you suggest they do from there if this person was exhibiting some of the other symptoms and they scored a 21? Would you move forward with an appointment with a neurologist?
Yeah.
Should that doctor go ahead and start some of these? So I go to one of the caregiver. So I live over on the other side. So I go to one of the caregiver things. We meet twice a month, and they're
Can you tell everyone what that is and where they meet?
So I think it's the Delta County. I'll have to find it.
You drove here from Delta?
I drove from Paonia.
Okay. Yeah,
Oh, it's ASEDD, which stands for something.
Alzheimer's.
Awareness, support, and education about dementia for Delta County.
That's amazing.
And they meet at Cedar Edge, Delta, and Hotchkiss.
Okay.
So I went to them because I wasn't sure what was going on with this person. And they've kind of been coaching me on things I should do, but they feel that the doctor who did that, and he scored a 21, that they should get him on medication as soon as possible.
Yeah, I mean, medication is such a personal choice, especially what I've told you tonight about the limited effects. You know, we can't overpromise individuals what these medicines can do. There are some hopeful things coming. Personally, and we have done a trial like this in the past, I think the way this is moving is that you're gonna be in your 40s or your 50s, you're gonna get a blood test that's gonna say you're at risk, and you're gonna take a medicine before those plaques ever develop. That's what I think will probably happen long term. But for someone in a situation where they're already scoring a 21 out of 30, the first thing I would say is they definitely need to be in with their primary caregiver just to make sure it's not something treatable, right? So you check their lab work, you check their B12, their thyroid, get a brain scan, and then you would wanna know if they were a candidate for some of these medicines, you'd wanna know their amyloid status. So all that can be done by either a neurologist, there's a neurologist, I believe in Hotchkiss.
Montrose.
Montrose.
It's Montrose and Grand Junction.
Okay.
And it's taken a year and a half to get into a neurologist in Grand Junction. We don't go until June.
Okay. What is our rate right now? 3 months. Yeah. If you talk to Shelby, I mean, we'll bump you up on the list. We're happy to see you. Dr. Heyman is in Montrose, and then a bunch of neurologists at St. Mary's, but you're right. It's pretty limited. Jeff Thornton is at Valley View Hospital as well. He has a pretty long waiting list too. It is tough, but we're happy to help. Primary care can order some of that too.
Yeah, he's very hands off. I don't think he just like, just go to the neurologist. He's relatively new, I think, and a new doctor, and I think and my husband is a little complicated too with other issues that he has, so mistake.
Okay. Yeah. We're happy to.
Body tremors. Sleeping, which leads to cognitive
Fragmented sleep. Yeah. Are you talking about yourself? Okay. Tremor can come from a host of reasons. You can get tremors just from having arthritis in your cervical spine, right? So that's one thing that probably needs to be checked out. Most tremors from Parkinson or true neurodegenerative processes actually don't happen at night while you're trying to sleep, and they don't keep you awake. So that makes me wonder if it's something in your brain or your spinal cord. So I think it would. Head injury, yep. So scars in the brain can definitely cause tremors like that. Patients that can calm those tremors though, because sleep is extremely important. Yeah, do you have a good primary care? Yes. I would talk to them and they're welcome to call me too, and I can give them some advice. Yeah. Sure. That's a good question. Yes. Alex.
Yes. I have a question from somebody watching from home.
Oh, okay.
The question is MAID, M-A-I-D, appropriate for Alzheimer's patients? How can it be done if you're not mentally fit?
I don't know what MAID is.
You're gonna ask clarification.
Yes, let's ask for clarification. You also have a question?
So the obesity, diabetes, the sugar,
factors.
Do they also, I guess, would they also actually create
Amyloid plaque. So that's really a question we don't know the answer to. I think the creation of amyloid is this final product that we're seeing at autopsy or at brain biopsy, which is very rarely done. And there are so many factors that lead up to that. I mean, we know just from a temporal standpoint, the time period that it takes to put down enough plaque to have a symptom. So there are so many things happening that it's hard to say, how does high blood pressure play a role? How does inflammation in your body from diabetes play a role? How do plaques in the blood vessels play a role? We just don't know the answers to those questions. But we do know that there is this correlation with addressing vascular risk factors and reducing your risk. And to me, I mean, we all want something we can do. These are tangible things you can work on and do.
And if you were gonna pick one thing out of that list of all these things.
Smoking.
Yeah. Cause you
Not
kept coming
smoking.
back to socialization, it seems like.
Smoking.
Yeah.
Yes.
I have some, MAID, is medical 8 and 9.
Oh,
So
thank
along the
you.
lines of assisted.
Thank you. So the question is, can someone who has dementia participate in medical aid in dying? Is that the question?
Yes.
That's a great question. So in the state of Colorado, there are very specific rules about who can request medical aid in dying. And one of the requisites is that you not have dementia. Part is that you verify that your memory is okay. And, it are only in who will do involved in are patients with ALS who conscious decision. And to be honest with you, the cases I've been involved with, they've gotten the medicine, but they've actually gone through hospice and they've died naturally and not by taking that medicine. But I think there was just some agency in having that medicine on hand for them. So unfortunately, I mean, or fortunate, however you want to think about this, that they would not be a candidate for that medication. The other thing that is a rule in Colorado is you have to physically be able to administer the medicine to yourself. So if you have any kind of swallowing difficulty or motor difficulty, which makes ALS a little bit tricky sometimes too. Yeah, I mean, I think that's the whole other talk of how we treat humans and pets and all kinds of different things. But then there's a very equal valid point that patients who have dementia are sometimes still living really beautiful lives. And so I understand why there's controversy on this, for sure. Yes.
If you've had depression for a long time and have went through therapy and you're over that and you're starting into some kind of a dementia, I mean, it's probably been 20 years that my friend has been out of counseling, and but started a few years ago of going into some kind of a dementia. Would depression have caused that?
Did your friend have ECT, electroconvulsive shock therapy? Not as part of their treatment. ECT is notorious for causing memory trouble, so that's why I asked. So I think two things can be going on. right? That your friend may have depression and may have a totally unrelated dementia, neurodegenerative process developing. It may not be related to his depression or her depression. We know that depression is a reversible cause of memory loss. I have seen dramatic cases in my office where patients come in, they're repeating themselves, they score an 11 out of 30 on a MOCA, and they look terrible. And we put them on Prozac, for instance, and they perk up and their MOCA score is 28 out of 30. I've seen people debilitated by anxiety who have terrible memory, and you treat their anxiety and their memory's better. So I think those cases exist, but it may be that this individual has something else going on. It's hard to know.
He's on, he's on memetine and
He's not doing well. Yeah. And then as we talked about, you can also have depression even before you ever develop dementia. Is that part of his dementia? I mean, that's another possibility.
yeah, I guess that was my question.
That's hard. Yeah, that's hard because individuals who are depressed tend to not want to do other things. They don't want to get out. They don't want to be social. They don't want to exercise. They don't want to go to the clinic and get an infusion. It's a really difficult case when that happens.
Is it the neurotransmitters that are involved in depression that actually create the brain?
So specifically individuals with mental health components that are causing their memory trouble, they tend to have the most trouble in two categories, and that's attention and concentration. So when you do that neuropsych testing, you can really tease out, hey, is it a true memory problem or are they just not attending to the task? Same thing you do with hearing impaired individuals, right? Because did he hear me say those 5 words in the first place? So you really have to tease that out. But if it's a problem with attention and concentration, it does tend to be related more to mental health.
Even though, so people could be misdiagnosed as ADHD.
Yes.
Or
dementia.
Yeah.
Yeah.
It could be
That happens all the time. Yeah, I mean, I think a good rule for ADD, it's not really ADHD, it's ADD. You know, if you get a new diagnosis of ADD in your 40s or 50s, that's probably not right? I mean, unless you can really recall all these instances throughout your life that you had those symptoms, I think there's probably something else going on. Well, you guys have been great. Thank you so much, and come see us in a minute.
If you guys want to sign up for the memory screening day, Leslie and myself can do that, or you can always call us too. Whatever works. Okay, what time?